Hi, we are here at the International Myeloma Workshop, the 17th one, here in Boston, September 2019, and it's my great pleasure to welcome for this debate Dr. Elena Zamagni from the University of Bologna in Italy and Dr. Joaquin Martinez-Lopez from the University of Madrid in Spain. I'm Mohamad Mohty from the Sorbonne University in Paris. And I thought today that we need to discuss MRD, because when I look to this meeting, and if I have to summarize this meeting into like a few keywords, probably MRD is the number one. So maybe I'll start ladies first. Yeah, sure. I'll start with Elena. What is your overall thought about MRD or take-home message from this meeting, and then we'll go into the details.
Okay, so for sure you are right, because many treatment options nowadays are evaluating MRD as an endpoint, or primary, secondary, or however we do have this evaluation. So now we are starting to collect a lot of data up front, but also in the relapse refractory setting. And we are seeing more and more triplets combination that are ensuring a higher rate of MRD. We have this in the context of the new CAR-T treatments. So there was a good discussion the other day about the fact that MRD could become an endpoint, a surrogate marker for survival outcomes. So I think that for sure it's very important to speak about this, because we also have to be sure to speak the same language, and so not to compare apple with pears. And
what about you, Joaquin?
I agree with Elena. In my opinion,
always you need to agree with
always.
Elena.
Yeah, sure.
Always.
I agree with Elena. I think the most important thing for me of this Congress about MRD is that conventional criteria of CR are older, and in the future we are going to look to MRD as the main objective of our therapy. Not just CR, we have to obtain MRD negativity.
Okay, let's now dig a little bit more into the details, because the devil is always in the details. First of all, when I speak about MRD in multiple myeloma, what are the techniques? Because I heard a communication from Dr. Loiseau, who compared NGS to flow, and apparently they are the same. Do you share this opinion?
You want to start?
Yeah. We have a lot of experience. Also, we have the same experience in the Spanish myeloma group. Although MRD by detection by molecular, by next generation sequencing is a little bit more sensitive, the prediction of clinical outcome of next generation flow cytometry and molecular by next generation sequencing are similar. So we need in the future have some studies comparing both methodologies head to head.
But I thought that what Hervé Loiseau did as part of the Cassiope trial, where they tested the samples simultaneously by NGS and NGF, the results were the same.
Yeah, but we have this is very confusing. We have to work on that. Now we have a lot of categories in myeloma. In the last definition of MRD, we have a lot of categories of response. We have flow cytometry response, immunophenotypic response, molecular response. We have to put all together because I think are intercambiable.
But if tomorrow I have a lab, you know, I'm at the hospital, I have a lab, and my CEO of the hospital who's willing to allow me to get a technique, how can I choose between these two methods?
I think depends on your expertise or the availability in your laboratory.
Okay,
I agree. I think that the expertise is the most important thing. Yesterday, Hervé underlined the fact that probably this little discrepancy that apparently is making NGS more sensitive is due to the sample, the quality of the sample, because he was mentioning that with flow you need to have a fresh sample, and maybe in the shipment some cells will die, and so in the end you have less cells than with NGS. On the contrary, with NGS you really need to be expertise, and you of course have to build the primers patient specific, so there is not really an optimal 100% technique over the other. What is important is to look correctly into the sample. So if you have in your lab, for example, people that are trained for one technique, maybe this is the preferred one for you. I mean,
okay, so both of you feel confident about the techniques we have.
Yes, I think
as long as we have the right expertise.
All the data that we have now are mostly on 10 to the minus 5. We should learn more about the higher sensitivity, so that for sure is the best. But
let's talk, I mean, you're bringing a very important point. Let's talk about the threshold.
Yes.
We see studies with 10 minus 4. We see studies with 10 minus 5. And now more and more I hear about 10 minus 6 as being really the holy grail,
yes,
you know, to achieve, because we do agree, I think, all of us, that the deeper the response is, the better it is. So what is the current recommendation?
That's for sure true. The more you have, the more is better. That's logical. However, the International Myeloma Working Group is still pushing to keep the 10 to the minus 5, because we have a lot of data in clinical trials with this threshold and very few with 10 to the minus 6. The number of patients is really lowering. So you have, of course, to have the Ferrari of the situation, but you also have to need to drive it, you know.
Okay,
so
but at the end of
if you
the
have
day,
something perfect that no one can reach, it's not
yeah, but at the end of the day, I would like to identify those patients who are really maybe are going to be cured. Mm-hmm. So it's okay, they are maybe a minority, but I really want to identify these patients. Do you agree?
Yeah, but we have to learn of, for example, chronic myeloid leukemia. And this is very important, the sustainability of the response, because we are now, most of the study looking to one point, and I think this is not enough. We have to look several points and to see that the molecular response or immunophenotypic response is maintained. Okay, and so this is very important.
So we talk about the technique, we talk about threshold, and now you're bringing the frequency. So you are suggesting that it needs to be repeated, because obviously we need a sustained response. So do we have an idea when to do it and how frequent?
No, we don't have several studies about that, but
let me take a concrete example, because I know it's impossible to have a global picture. A transplant patient, I do my 4 cycles of induction, I do my high-dose melphalan, and usually we look around the 3rd month for response. When do you think should we look to MRD? First of all, is it only in CR patient, or can we look in VGPR patient?
In my opinion, we have to look in CR patient, but
CR. Okay.
We have a lot of patients that have oligoclonal bands, and it could be like in the middle. And in this patient, I will do it also, and of course in CR patient, because
so CR patient, when, after transplant or before transplant?
I think it's important before, because in this Congress, the UK group, the British group, showed that the patient that achieved very soon before transplantation MRD negativity have better prognosis than the other one. And also after transplantation is when we have more experience. And then...
So when after transplantation? 3 months?
3 months.
3 months.
In the moment that we have we perform the bone marrow assessment at 3 months, usually.
Okay, so if the patient is MRD negative at 10-5 at 3 months, when do you repeat it?
It's important. We are not going to give more treatment. Not make sense, but if we are going then give maintenance treatment, we perform in our center every month. Every year.
Every year.
So the patient maintain.
What is the practice in Bologna?
We are doing now every 6 months, but I don't think that this can be proposed
on a wider scale.
We still would like to sort of
because you need
have
to do a bone marrow
yes,
aspirate.
You need to do a bone marrow, which is of course. I think that sustained MRD, it is to be considered at least with 2 determination, at least 1 year apart, but I'm not sure if this is the optimal or not the optimal, and well, he was mentioning the CML story, and I think we still have a lot of way to do to reach the precision of recommendation that they are giving to people. So I agree that you may absolutely not just pick one MRD negativity to state that the patient had to stop maintenance or go on or reduce or something like that. We cannot make this recommendation nowadays. For sure, we still have to look more deeper.
But Joaquin mentioned you pronounced the word maintenance and guiding therapy. Are we ready to use MRD to take therapeutic decisions like the guy? Okay, let me give you the scenario. MRD negative 10-6 after transplant. Should we give maintenance?
I will never tailor treatment nowadays on MRD. That's too early to me.
In some special situation, we can do it. For example, in patients
that... what is it you can do it? You can avoid maintenance therapy for this patient?
No. I agree with Elena. All the patients at this moment have to be maintenance because we show that is important, the maintenance. We have to maintain the MRD negativity. But in some special cases, like a patient that has tolerating very bad the maintenance treatment and is in molecular response, we can stop. We are doing that. We can stop the maintenance.
You feel more comfortable.
Yeah, and then we follow. And then we can follow the patient very close, and this increase the MRD. We can start again the maintenance or change the maintenance.
Okay, so
but I think, sorry, that on the contrary, the major problem we do have now is MRD positive patient, because what to do with MRD positive patient is...
So what to do, I'm asking you.
Is not clear at all to me, you know. Patients that are starting maintenance MRD positive and are staying MRD positive, should we in this patient go on with the same treatment that did not put them, put something else, another drug? This is really an open question, and I would say that, well, that's an issue. High risk MRD positive, that's a big issue because we know that those patients have a very dismal outcome. So what should we do with those patients? Change completely treatment, give a second line, for example, consider them as a resistant and push them to another treatment. This is something that's truly...
Well, maybe in high-risk cytogenetics that can be a wise decision, because we know their outcome is really very bad.
But we don't have, we are guessing this, we don't have any data on this.
Yeah,
okay,
but
so we can think
I'm not
that's
aware of protocols
wise,
with high-risk cytogenetics exclusively. The numbers are small.
Yes.
In this case, there are other situations that the measurement of MRD could help us when the patient is MRD positive and we are giving maintenance and the MRD is going down. We can be sure that the patient probably is going to be going to have a good prognosis also, and we should maintain the treatment. And of course, if the patient is high risk and the MRD negativity is stable, probably I change the treatment.
Okay, so besides the biological MRD, especially you, Elena, you worked a lot on imaging, because in myeloma, it's a bone disease, and we can see, I think, MRD negativity biologically, but your PET scan is still positive, for example. So how can we combine both approaches to make sure that the patient is truly without any measurable residual disease?
Yes, the recommendations are to perform both techniques inside and outside the bone marrow. So for sure, if you find both negative, that's really a plus for the patient. You know that the outcome is the best one. So
I'm on the safe side.
Yes.
Yeah. Okay.
What to do when either of the two is positive? We know that the prognosis is intermediate and is in the middle, but we don't have any protocol saying what to do exactly. For sure, I think that you can recommend a follow-up because some patients can relapse only outside the bone marrow, and well, the Spanish group demonstrated this. You know, so if I have limited resources and I have to say who are the patients that I absolutely want to follow up with PET, I may say the extramedullary, the hyposecretory, the paramedullary disease, and during the relapse, because during the relapse we know that we can have relapses outside the bone marrow and not inside, you know, so if I have to choose, otherwise, okay. You know.
But you said in your institution you're currently doing like every 6 months bone marrow and looking into MRD. So does that mean that you're also performing a PET scan or an MRI in parallel?
We are performing a PET scan just prior to maintenance, so, well, to determine. If it's negative, we are stopping because we showed many years ago that those patients, there is a very, very low risk of relapsing only there.
But if it is positive?
If it is positive, yes, we are following up.
You
of course,
repeat
once
it.
per year because you cannot propose a PET every 6 months. It's not possible.
We are doing the same. But we have, in our experience, we recently published, if the patient have PET positive, have very bad prognosis. We are treating this patient. We are changing the treatment of this patient. Relapse very quick.
So what I can understand, the techniques are there, they are reliable. We're starting to better understand the issue of threshold. The frequency, the sustainability, we do have some good ideas. Obviously, we are missing the prospective protocols to use it to guide therapy or to drive therapy. And we have seen at this meeting a lot of discussions, including representative from regulatory bodies, about using MRD for drug development and approval. And it's like in between. Apparently, we're not yet mature enough. Do you share this opinion?
Yes, I think we are on the way, but well, not really.
Well, what is missing? What are we waiting for?
I think it's very important the standardization. This is the big problem of MRD.
But if you take NGS, I think these days we do have commercially available kits that are standardized, FDA approved. That can be fine.
Yeah, but at this moment is not very available, and we need some people are using flow cytometry because most of the cooperative groups are using flow cytometry. Or in the pharmaceutical company are using molecular, and this is very confusing. Also, the criteria are not very clear, and we have to work on that to be sure that.
So besides standardization, what should we bring? Because now these days in myeloma, and this is really good news for the patient and for all of us, the patients are living really long. Even patients in relapse are able to achieve a long survival and MRD negativity. So what is still lacking to convince that maybe MRD as a primary endpoint and maybe PFS and overall survival as a secondary endpoint can help to accelerate drug development and approval?
Well, for sure, this that we were speaking before about the sustainability of MRD, if you have to push for drug approval, you have to clearly state what you mean for MRD negativity, because if it's not true that it's just one determination, so when is the second, with which...
But you said 1 year.
Okay, but this is something practical. I mean, that's not something evidence-based, you know, so...
Okay.
No, but I am very positive. I think it's going to be in the near future primary objective of several clinical trials. I saw in this Congress that it's going to be in the near future.
Okay.
Yes, so you mean that more and more trials have this as a primary endpoint, so for sure all the analyses that we had until now were retrospectively applied to different endpoints. So if now the primary endpoint is that one, probably the authorities are more happy to take it as well an endpoint also to compare the drugs. I mean.
Okay, so we're talking mainly about the frontline setting, but you mentioned that even in the relapse setting, thanks to many potent drugs and combinations, we are even able to achieve MRD negativity in the relapse setting, which is really amazing. So should we also introduce MRD monitoring as part of the relapse setting?
For sure, in the early phases, yes. We
First relapse?
Yes, first relapse for sure. Okay. We have this data on daratumumab, but unfortunately we don't have on KRD, XRD,
so
on
you're
the other
alluding
triplets,
to the Pollux and Castor trials.
Yes.
Okay.
Unfortunately, we don't have with the other triplet because it was not the case, but I would like to know for sure in the high risk, not high risk, so. And we have extensive data on CAR-T, so very late phases of treatment. We know that in that context, for sure, the value of MRD is less clear and less. So I'm very interested in CAR-T in earlier phases. What will happen with MRD, for example, because well.
So this is very interesting because I agree with you. We've seen in many CAR-T protocols and results
a single MRD negativity, and
patient would achieve
relapsing.
MRD negativity very quickly.
Yes,
but
relapsing.
Still, unfortunately, CAR-T are not allowing to cure the patient because we've seen median PFS 12 months, 11 months, 15 months. So how do we explain this? Is it the threshold that is not the right one?
I have the answer.
Please do.
Is the sustainability of the
sustainability.
Yeah, I am now in UCSF. I am collaborating with the UCSF team. We are reviewing all the MRD data in CAR-T cells, and the deep response is very quick, but some patients relapse very quick, and before 6 months, and the key is the sustainability, because probably the CAR is not going to sustain the response in some case.
The key point for a better outcome would be deep
and sustained
MRD negativity and sustainability.
Yes,
well, that was amazing, because I believe, and I think we all agree, that MRD evaluation is really becoming a key component of the management of multiple myeloma. Obviously, we have to include imaging techniques. The techniques are reliable, they are available, and hopefully we'll be able to use this soon to develop and accelerate the development of drugs and approval, because at the end of the day, we really need to have all of these novel agents rapidly available for all patients everywhere. And of course, affordability is important. Sure. So thank you very much, Elena. Thank you very much, Joaquin. That was absolutely terrific. Thank you.